Yeah. One important thing you will see when you are talking about dural fistulas is that if you take 10 cribriform ethmoidal fistulas, almost all will look the same. They will look absolutely same. I will think it is your case, you will think it is my case, because the anatomy is very, very constant. The venous pathways that are taken by the fistula are very, very constant. The vascular channels that are taken are very, very constant. So this was an elderly male. He had presented to us with subarachnoid hemorrhage, actually. The subarachnoid hemorrhage was obviously because of what we are seeing here is... What we are seeing here is, these are the external carotid injections. In fact, in a distinction, in a variation from what we saw in Dr. Deep's case, where there was no supply or no prominent supply from the ECA, we found that the entire septal vascular network of the nasal cavity was anastomosing via very thin filaments and was supplying the fistula distally. So we automatically started realizing that even though this is a dural fistula, the primary supply to this dural fistula, even though it's coming from dural vessels, for example, you can even see a middle meningeal artery which is going up till there and supplying it. The middle meningeal artery course was quite tough. In fact, from the other side was the middle meningeal artery which I showed in the previous lecture from the same case. So middle meningeal was not an axis which we could use in this case. And even the sphenopalatine artery, just let's spend some time here for the younger colleagues. This is the distal internal maxillary artery. From the distal internal maxillary artery, you are having the middle meningeal artery, which is going over here. This middle meningeal artery is going through the foramen spinosum. The moment it reaches intracranially, it goes along the base of the skull and then ultimately reaches the convexity, the lateral part, and then ascends upwards in the groove on the side of the skull and goes to its territory. So that is the middle meningeal which is coming from the internal maxillary artery. From the very distal internal maxillary artery, this artery is the sphenopalatine artery. The sphenopalatine artery, this is a foraminal division. This is the sphenopalatine foramen. In the foramen, it is dividing into two distinct branches. You can see that there is one branch which is coming to the lateral aspect of the nasal cavity, and you are having one more branch which is crossing over the bridge of the nose, under the bridge of the nose, and is going to the septum. So that is the septum. These are the septal branches, and this is the anastomosis of vessels on the nasal septum. The lateral branch, which is originating as an inferior branch from the sphenopalatine, is coming downwards. And while coming downwards, it is giving three branches. It is giving a branch to the superior concha, it is giving a branch to the middle concha, and it is giving a branch to the inferior concha. So you have the lateral branch, the medial branch. The medial branch is the nasal branch or the septal branch. This is the branch which interacts with the branches of the anti-ethmoidal system. And this is where you have anastomosis with the anti-ethmoidal system, and then to the ophthalmic artery, and then ultimately to the ICA. Whereas when you are in these branches, when you are in the lateral branch, that is the conchal branch, which gives rise to the superior, middle, and inferior turbinate arteries or conchal arteries, the moment you have a vascular malformation in the nasal cavity, if you are trying to embolize, if it is on the septum, you have to cross over to the midline and then go into the descending segment and then embolize. Whereas if you are in the lateral branch or in the conchal system, the moment you leave this bifurcation, the moment this bifurcation can be pre-foraminal, foraminal, or post-foraminal, the moment you leave this and enter into the inferior branch, you're safe. So remember, whenever you are working in the nasal, in the septal branch of the sphenopalatine artery, you have to go very, very distal. But if you are working in the lateral branch of the sphenopalatine artery, you can be a bit more proximal and you can still get away with it. So in this situation, if we were to use the external carotid artery for embolization, we would have had to use the septal branch, and we would have had to go through the septal anastomosis and then ultimately into the foot of the vein. So difficult. Therefore, we started looking at other possibilities. Now we do the internal carotid injection on both the sides. we find that typical disposition of the ophthalmic artery, you're having ophthalmic originating from the supraclinoid segment. From the supraclinoid segment, it is going distally, and then ultimately the fistula is getting formed somewhere at this region. The fistula is getting formed somewhere at this region. This is probably the position where the artery is going from lateral to medial or medial to lateral, because we cannot make out on the lateral view. So you have to basically enter into the distalmost part of the circulation. You have to go around this bend, and then you have to engage into the ethmoidal system if you have any chance of curing this fistula from a transarterial route. So the catheterization up till this point is going to be relatively simple, but here there is a recurrent branch of the distalmost part of the ophthalmic artery which has to be taken, and then only after you take this branch you will be able to enter into the anti-ethmoidal system. The same problem is there on the other side as well. You have to go distally, and then you have to take the curve, you have to take the recurrent branch, and then ultimately you have to enter into the venous pouch. So we decided on a bilateral arterial approach. We did 2 punches, both the groins. We cannulated both the internal carotid arteries, and then we started the catheterization. As I already showed before, this was the catheterization of the right middle meningeal system. We've realized that the middle meningeal system is going to be a very difficult target, because these bends that are seen on the, these bends they can be negotiated very easily. But when you come to the distal part and you see these couple of loops, these loops, this one over here and the one below it, we were not very sure if our microcatheter would have gone through those loops. So we decided to keep this as a reserve, and we went ahead with the catheterization of the ophthalmic artery. Now this is the catheterization of ophthalmic artery on one side, and this is the catheterization of the ophthalmic artery on the other side. We can see that we are still quite proximal, even though it appears as if we have crossed the point of supply to the visual system, still not to take any chance and still to account for any reflux. We decided that this catheterization is not good enough, and subsequently we tried a bit more on both sides. So now you can see that this is the carotid siphon, this is the origin of the ophthalmic artery, this is the so-called bend in the ophthalmic artery. We have gone much distal to the bend. Now we have gone distal to the bend and taken the recurrent course of the ophthalmic artery. And from the recurrent course of the ophthalmic artery, we are able to inject into this entire system, which is a part of the anterior ethmoidal system. And this entire anti-ethmoidal system is getting opacified, which is subsequently going and filling the fistula. The fistula point is a single point. This is not a fistula point. This is just a curve of the vein. This is a basifrontal vein, which is ultimately going and draining into the basal vein of Rosenthal, and this is ultimately going into the posterior circulation. So even though this patient had an anteriorly located fistula, the venous reflux was almost up to the posterior part. That would account for most of his symptoms. So once we were in this position, once we were very comfortable that we have reached a very good position for glue embolization, we did bilateral injections. Right ICA, right ophthalmic, left ICA, left ophthalmic. We generally look at microcatheter runs to understand the fistula better. We also use, very importantly, for example, if I'm trying to inject glue from this side, I do not want the competing flow from the opposite side to wash it off from that area. So just putting a microcatheter in that area, in that tiny vessel, reduces the flow by a factor of maybe 3 times. So even though I will be injecting from the right side, I will keep a catheter in the left side for flow control. And later, if I'm not able to take the entire fistula out from this side for injecting in a second session, immediately after the first session. So this is what we did. We catheterized both the sides, and once we catheterized both the sides, we were able to have a very good penetration of glue in the entire fistula bed that I will be showing you in the unsubtracted fluoro. We closed the entire bed of the fistula But unfortunately, we did not have a significant penetration into the vein. The fistula was gone completely by both the common carotid injections, but we knew that since it has not entered into the vein, the chances of this coming back are very high. That's why we went ahead with a transvenous approach. Now, for a transvenous approach, the approach, our hardware is pretty straightforward. We use a triaxial axis. We keep guiding catheter, any guiding catheter. It can be a chaperone or it can be a ballast or whatever in the bulb of the interjugular vein. Through that, we take a distal access catheter. It can be anything. It can be a Fagomax. It can be a Cat5 or whatever. And then through that, we take an over-the-wire microcatheter. So this is what was done in this patient. We were able to negotiate and we were able to reach the point where the venous system was originating from the fistula. And finally, we injected some glue, antigrade from this level as well. You have to remember that you are injecting against the flow. So you will have to request your anesthesia team to bring down the BP. Maybe sometimes we do the rapid pacing as well to make sure that the glue sticks there. And then at the end of it, you finish the embolization. And that is your entire glue cast on the floor of the anterior cranial fossa, as well as extending into the vein. In the floor of the anterior cranial fossa, as well as extending into the vein. So this is when you know that you have occluded the fistula completely, and this fistula most likely is not going to come back. These were the final injections, the AP and the lateral projections, and patient did very well. The ophthalmic artery is completely preserved. You can see all the branches, even distally, they are quite well preserved, and no effect to the vision at all. This is the opposite side, I believe. The same side. This is the ICA run, and this is the CCA run. The ICA run and the CCA run. So this is where we finished off the fistula. This was a long case, and we had catheters in the arteries for quite some time. So we had a little bit of a thrombus developing there, but this was taken care of with integralin and heparin. And we did not have any ischemic complications at the end of the procedure. So any questions on this embolization? Any questions, any comments, if you want to ask? Because two different ways of doing the same thing. Dr. Deep showed you how we treat this with Onyx. I showed you how we treat this with glue. Dr. Deep showed you how we can do this from the trans-arterial approach. The difference between Dr. Deep's case and my case, that was predominantly a fistulous connection. That was a single large fistula. But here we had, it was like a direct CCF, if you want to make that comparison. But this situation was like an indirect CCF, in which you had the arterial twigs going and ramifying on the surface of the vessel and then supplying the fistula. So that is why the technicalities are slightly different in this case. The glue concentrations is slightly different in this case. If we would have done that case with glue, we would have used a 50, 60, 70% glue. This case we did with maybe a 30, 35% glue. Here we were in a wedge position, so we were able to push the glue quite further. In that case, you were not able to achieve a wedge position for the simple reason that the arterial pedicle was very large and the microcatheter was very small. So two different ways of doing the same thing. So if you have any comments, any questions.
Rahul, what catheter you used here?
For artery?
Arterial.
Marathon.
Marathon.
Marathon. Yeah. Our go-to in most of the cases for glue is Marathon. I like Magic, but the problem with Magic is Magic 1.5 does not accommodate many wires. Marathon 1.5 accommodates whichever wire I want. Yes. It accommodates a Traxxas, it accommodates a hybrid, it accommodates a Mirage, a Chikai, whatever you want. So that is one, because the wire is actually the most important part of this catheterization. So basically, I would love to use any microcatheter provided I can use my choice of wires.
Absolutely, absolutely, yeah. I mean, both the cases, I think, two different ways of embolizing, and I think whichever you're comfortable with, I think that should be the way to go. The alternate options, I mean, of late, people have been doing a lot of these cases through transvenous approach. You did have an access, and your case was also feasible for a transvenous approach because the from the superior sagittal sinus, the vein takeoff was quite favorable. It was not unfavorable. And one other perspective, looking at from the other side, these fistulas are fairly straightforward for a surgical clipping as well.
Absolutely.
Yes.
Because you just lift the brain and there you are.
Absolutely. I mean, we do a bifrontal craniotomy. We just take the orbital rim as well, so we get to the base. And as soon as you open the dura, you see the vein.
Exactly.
You can clip the vein. So that is also an option we should keep in mind.
Absolutely. Absolutely. In fact, I would feel that surgery should be the first option to be offered to these patients because these catheterizations are not simple. And these catheterizations should not be attempted in the beginning because the chances that you fail are much higher. So till you get a feel of embolization, till you can control your embolic material, better to send these cases for surgery. This one, or for example, yesterday what Paritosh was showing, some of the dural fistulas of the spine, where you can see nicely which nerve root exactly is involved. You just do a laminectomy and coagulate. That's it. Your case is over. So surgery has to be kept as a very, very viable option. These days, patients themselves ask, is there any other option without doing a craniotomy? So that is the time when we push this, or if the patient is very sick, if the patient is not a very good candidate for a surgical process, risks are high, then we go for this.
The venous drainage is in the deep venous, no?
Both, superficial and deep. You have both. You have drainage in the deep venous system also, and you have drainage in the superficial venous system.
Prominent one, this deep venous, no? Prominent one is deep.
Yeah, I'll say equal. I'll say both are equal. Why you are not seeing a prominent flow in the superior sagittal sinus is because the normal blood from the rest of the brain is washing it off. So the drainage was equally divided probably.
Can you go through this?
Deep venous system, too tortuous. You can go through it, but too tortuous and not worth it actually. In fact, what happens is these veins are lying loosely in the subarachnoid space.
Yeah.
So if your roadmap is completely useless, the moment you put a wire there, the vein will shift. So you will be essentially going blind. Your roadmap does not help you at all. Why we like the sinus is going to remain very constant. But the problem in the sinus is all these veins, all these cortical veins, when they enter into the sinus, they enter at an angle, that's number one, and they have a long course in the wall of the sinus. It is not that they enter the sinus with a straight hole. They travel in the wall of the sinus for some time, and then they open finally into the sinus. So negotiating that segment sometimes becomes a problem. In the frontal, it is not much of a problem, but as you come more and more behind, the angulation of the veins becomes more and more acute and against the direction of flow. It is like a valve-like mechanism. Straight sinus will not be a challenge. This is very easy. This is very easy. In fact, if you want to access, supposing you had a dural malformation somewhere here near the vein of Galen, accessing that is very easy actually. In fact, this access is much more difficult. When you are reaching there and then ultimately you have to reach this point. See, I was lucky because I finished off this area from the transarterial and then all I had to do is inject a drop of glue somewhere here. But if you are doing a pressure cooker and you are trying to penetrate from above, you have to enter into this venous segment. Now, this is where the challenge is. Endovascularly, from the superior sagittal sinus into the cortical vein, when you enter, that is where the challenge is. Straight sinus is straightforward.
Yeah, and for people like who are not very clear with the venous anatomy here, Rahul, can you just show them the foot of that one common vein, and then it divides into the one going to superior sagittal sinus, then one going into deep venous system.
Yeah. See, that is the foot
that
of the
vein that is going up. That is what we need to get. The rest of the venous system all will fall in place.
This will collapse.
Correct.
This is not a problem.
But
this vertical segment, this vertical segment is the problem. And
is a common vein.
Is the common vein. That is the first vein which is originating, because you have all the cortical veins, deep veins, they are interconnected anyway. So whichever way the flow has to go, it will go. But as long as you disconnect this common collector, that's what we did in the, I think I'll have it in the glue cast. Yeah, you can see this vertical portion, this tiny vertical thing here. This is the glue cast in the foot of the vein. This vertical thing here, this is the glue cast in the foot of the vein. All this which has gone extra, that was not necessary. Even if it wouldn't have penetrated that much, it's not a problem. Yes? Anyone? Yeah, all the coiling catheters are compatible with glue. There's absolutely no problem. Marathon, you are going against the flow. So marathon also will have to be tracked over the wire. So when you are tracking over the wire, better to use a coiling catheter. Because the flow there is so much, in fact, you could see that, the flow there is so much that it is getting washed off completely. You are injecting the contrast here, it is going only up till here, rest of it is getting flow. So if you have a marathon there in a huge sinus, it will just keep on flopping there. So you will have to use a wire to straighten it. So when you're using a wire, use a over-the-wire catheter, double-tipped microcatheter. Contrary to what a lot of people believe, every embolization does not have to be done with a flow-guided microcatheter. I'll say 60% of embolizations will be done with a flow-guided, 40% can be done with any microcatheter that you have in the lab, provided you understand that microcatheter, how it behaves, how it feels. So whatever you use, just keep them, because in some case you might be able to use them for embolization also. Any more questions? Any more comments? No more questions? Because we have another 40 minutes, and I just have one or two more, because Minzil's 2 talks I have condensed them into one. So we have some 20-30 minutes. If any doubts are there, we can re-clear them, or I will show you another case of veno-lymphatic malformation, which was not treated endovascularly. It was done under local guidance, local puncture. So before we go into that case, any more comments, any questions? He passed away. He did not do well. The patient who had the infarct and the subarachnoid hemorrhage, he did not do well. No, because there was already a lot of space in the cranium. There was no mass effect as such. And as it is, the patient was in a very bad condition, elderly male. So we offered to the patient, but we did not do anything.